In 2006, family planning centers here in Westchester County served about 35,000 of those 41,000 women, which when you do the math works out to about 85% of those women in need were served by family planning centers in Westchester County. That's an extraordinary number. I mean, I'm watching your eyebrows go up. It's an extraordinary number. Nationwide, family planning centers are able to serve about 40% of the women in need of services, and private doctors are able to serve an additional number of women who are eligible for care under Medicaid. So the total percentage of women in need whose care is met nationwide is about 50%.
So you're saying then that we are failing to meet the contraceptive family planning basic health care needs of 50% of the women who are disadvantaged?
I think we are, I think we are working very hard with extremely limited resources. But I think we, as you say, we have a long way to go. And I think one thing that we need to do is to find the resources to do a better job of being able to reach out into the community. Not only are there more women in need than there used to be, nationwide, the number of women in need of publicly funded family planning services went up by 1 million women from 2000 to 2006. That's a big jump. At the same time, the population of women in need is changing and becoming more diverse. The proportion of low-income women of reproductive age in this country who are foreign-born, who are immigrants, doubled from 2000 to 2006. Doubled. That's significant for a whole host of reasons, but it is very significant for family planning centers and family planning programs who are trying to reach those women, to provide the kinds of culturally sensitive services that they need, to go out, to reach out into the community and find these women and encourage them to come in for services, to help them feel safe to come in for services. These are women who very often don't speak English or have only limited knowledge of English. There's a program run by Planned Parenthood in Wisconsin. It was one of my favorite programs, where they, do you remember Tupperware parties?
Oh, yeah.
From a million years ago? They do kind of the family planning version of Tupperware parties. And they run these home health parties in Latina neighborhoods, where they go and they sit around the kitchen table with a group of women on Sunday nights. And they just have to do it week after week after week until they feel safe coming into the clinic for care. These are sometimes women who have just complex lives. They're dealing with homelessness, they're dealing with substance abuse, they're dealing with mental health kinds of issues. And being able to go out and reach those women and help them feel safe and come in for services is a tremendous challenge. There are phenomenal programs that are working very hard to do that around the country. There's a program in California, for example, where they send outreach workers to go and basically set up shop in a homeless clinic. And they say they have to be there week after week after week, just talking to these women until, in the homeless shelter, until they feel comfortable coming in for services. All this, costs a ton of money, and it's money that these, cash-strapped programs have not had for a very, very long time. These programs took an enormous funding cut in the 1980s and are just now getting back up to their 1980 funding levels. Just now, all of these years later. And in the intervening time, any dollars that they had were put toward trying to provide services. And outreach and funding for outreach really fell by the wayside. So I think one challenge in front of all of us now is to try to find those resources and to do this outreach that is so sorely needed.
And the main sources of public funding for reproductive health services are what?
Well, we mentioned them both last year or 2 years ago. The Title X program. They were not in this sort of economic situation. Medicaid is an insurance program. Each state essentially runs its own Medicaid program, sets its own Medicaid eligibility criteria, and a woman needs to meet those criteria, enroll in the program, apply to the program and enroll in the program in order to meet services. Once that happens, she has an insurance card. She is a Medicaid enrollee. And she has a card just like I have an Aetna card in my wallet. And because she is a Medicaid enrollee, she is entitled to steps for a basic package planning program. Title X family planning services really are basic health care. It's a federal grant program, and the federal dollars flow to providers across the country, to grantees across the country. And they do very different things with those dollars. They serve the people that Medicaid...
Give me, first of all, some examples of who might be what kind of agency might be a grantee.
Sure. There are different kinds of agencies that are grantees. Most of the grantees, in fact, are state and local health departments. They can be Planned Parenthoods. They can be independent agencies called family planning councils, which are, again, nonprofit agencies that are set up solely to provide family planning services. In a couple of cases, there are community health centers. There are a couple of hospitals that can be grantees. So it's a range of programs and a range of grantees across the country. Typically, the grantees get the money from the feds and then disperse the grant money to actual family planning centers that provide the care.
And you say that the program is diverse. What kinds of particular strengths or weaknesses did you find in the national program in the course of your research?
Well, I think that the strengths that we found for Title X are the ways that it's such a good counterpart and a good partner for Medicaid. Medicaid will provide that clinical core of the services, the medical care. And Title X will really wrap around Medicaid to, first of all, provide care for those women who are not eligible for Medicaid, which in many cases are immigrants, either recent immigrants to this country or undocumented immigrants.
So our dollars are going to serve
to our sexually active who need their services.
U.S. citizens, but also
they are very careful and
recent visitors to this country.
Medicaid cannot cover undocumented women, and it cannot cover women who have been in this country less than 5 years. Title X can fill in both of those gaps.
Okay.
And Title X does, all over the country, fill in both of those gaps. Title X can fund services that Medicaid will not cover, and chief among those is counseling. Medicaid will pay the kind of basic off-the-rack counseling that everybody walking in the door needs. Title X...
Like, what are you saying?
Information about, the various contraceptive methods. Taking the client's history, learning what's going on in her life. The basic kinds of conversations that you and I have with our doctors. Medicaid can cover that. But Title X can swoop in and provide the extra counseling that maybe a homeless woman needs, or maybe that a very young woman needs, or a woman who's aging out of foster care, who just needs more than the off-the-rack counseling. Title X can provide the outreach services that we were just talking about. And absolutely critically, Title X supports this infrastructure. Title X keeps, puts those providers on the ground and keeps those providers on the ground, which is everything from paying the electric bills to buying the contraceptive supplies to those rolls of paper that they cover the examining tables with. And critically, Title X can pay for the human resources that are at the, fundamental to the effort. Title X can pay for the staff, the counselors, the people who sit at the, the front desk. Title X can pay for all of those people, and that's all stuff that an insurance program like Medicaid is simply not designed to do. So, these two programs really complement each other, very well, and together, if we are smart going forward and leverage both of their strengths, give us a good platform for going forward and meeting some of the needs that are staring us in the face. Under Medicaid, each state, as we said a minute ago, sets its own eligibility levels, as a proportion of income. Okay? Historically, eligibility levels for pregnant women under Medicaid are much higher than for other women seeking Medicaid coverage.
Okay. So pregnant women are more easily served under the typical Medicaid.
Right. A pregnant woman with a higher income can get onto Medicaid than an